Hello everyone, my name is David Reese. I'm an athletic trainer. I'm certified in the McKenzie method of mechanical diagnosis and therapy, and I'm a DNS exercise trainer. I've been to a lot of DNS courses recently, and when people find out I am certified in mechanical diagnosis and therapy, I'm often asked, how do DNS and MDT work together or complement each other, or should they take DNS courses instead of MDT courses or vice versa? And what I found in my personal practice as an athletic trainer is that they complement each other very well. In this video, I'm going to talk about the similarities between DNS and MDT. There are many. The differences between the two systems, and how DNS and MDT complement each other. And so here are some of the similarities between the two systems. And I think the number one thing for me that I find really attractive about both systems is that there's a heavy focus on clinical reasoning and problem solving, and that they're both systematic. Each system teaches you principles to use as part of your clinical reasoning to problem solve through those difficult patient presentations and to be systematic while you're doing that. Neither system, just like real life, is a linear process. You're going to be moving through your assessment and your treatments, and sometimes you're going to move forward, backwards, up and down sometimes, and repeat yourself sometimes. And what's really important is if you have strong clinical reasoning, strong problem solving, a system to go back to, it's really going to help you out in all of your patient care. So both systems have all three of these things. Both systems are movement-based. We move you as soon as possible. We move you as part of your assessment, and movement becomes your treatment. With movement's mechanical loading. With mechanical diagnosis and therapy, often we're looking at and trying to get very clear on direction-specific loads. What direction is the direction that decreases your pain, increases your range of motion, and improves your function? With DNS, we also look at understanding mechanical loading, except it's more of a focus on motor control and how mechanical loading and motor control affect each other. And then finally, patient education. Both systems teach the clinician to educate their patient, to send their patients home with things that they can do to manage their own pain, things that they can do to improve their function. So as we look at the differences between the two systems, it's really important to note that the differences don't make one system better than the other. What the differences really do is tell you when you're going to use one system over the other. MDT is a classification-based system. As part of our assessment, we're looking for those patterns. We're looking for that patient's pain behavior that tell us, is this a derangement? Is this a dysfunction? Is this the postural syndrome? Or is this someone we're putting in the other category? With DNS, we're looking at developmental kinesiology. We're looking at those known movement patterns that we're all born with. We're assessing our patient's ability to perform those movement patterns and then making our treatment decisions based on that. And even though we're talking about differences, the big similarity between the two is that we move these patients, we load these patients. And in the assessment of both, it's usually gravity and body weight, but that tells us so much. With MDT, we look for those direction-specific loads that are going to allow us to reduce a derangement, remodel a dysfunction, or retrain a postural syndrome patient. With DNS, we're going to look for that relationship between loading and motor control so that we know how much to load that person, or how much or how little do we need to load this person so that they can be successful in these movement patterns and so that they can train those and get better at them. So now let's get to the good stuff. Let's talk about how these two systems complement each other. Let's talk about how to integrate these two systems into your practice. As I talked about in previous slides, MDT is really focused on classification and understanding direction-specific loading, while DNS is motor control strategies based on developmental kinesiology. I start with MDT because of the power of classification, because in my experience, you can classify your patients in one of the MDT categories, you have a really great start to getting your patient better. Now, it's important to note, especially if you're looking at a patient population that's athletic, you're always going to need motor control strategies. You are always going to need to train the motor control system. It's just when in my assessment and rehab process do I do it. Like I said, I start with MDT because I want to know, is there a problem in the joint or is there a problem in the muscle that's going to affect the motor control? If I just simply start with motor control and there's a problem in the joint or a problem in the muscle, it may take me a little longer to solve that problem. I want to reduce that derangement first, or I want to remodel that dysfunction first, and then start to integrate motor control strategies. If we look at the typical treatment strategy with the derangement, we're going to reduce that derangement, we're going to maintain the reduction, we're going to do recovery of function, and then we're going to prevent future episodes. Once we're really clear in a derangement on the reductive direction, the direction that makes things better, and the patient is clear on that, and they know how to decrease and abolish their pain, improve their range of motion, improve their function, let's get DNS involved. Let's get motor control strategies involved, because there's a reason that patient deranged. And we especially see these people where the low back pain came on suddenly, but they don't know why. There wasn't a big event, or even chronic back pain that came on, and they don't know why. DNS is great, because then we're going to go into our assessments. We're going to look at how they can tolerate the loading. Do they move well under load? And if they don't, just like MDT, where your assessment becomes your treatment, our DNS assessments become our treatment. Also, with derangements, we want to maintain that reduction. With the MDT strategy, we're going to keep doing the exercise in the direction of preference. With DNS, we're going to use those motor control strategies to stabilize the joints, to strengthen the motor patterns, to strengthen the muscles around the joint in which that derangement is in, to help maintain that reduction. The motor control strategies will also help us recover function, will help us get to a place where we can be strong in any movement, any natural physiological movement of that joint. And we need to prevent those future episodes. We will use our MDT strategies. We will use our MDT strategies of a direction-specific exercise, maybe as part of our warm-up, maybe throughout practice or a competition, and then probably after practice or a competition, prevention-wise. And we can combine that with DNS to really strengthen everything around the joint. Like I said before, strengthen everything around the joint, strengthen the motor patterns so that those patients don't re-derange. Now, if we're treating a McKenzie-defined dysfunction, we know clinically that may look like a tendinosis, maybe a contracture, maybe some other kind of scar tissue in the joint or the muscle. We know that we can load that thing. In general, we can load the heck out of that thing, always watching for an inflammatory process, but it's going to take 6 to 8 weeks or longer. So let's use this time well. Let's use this time to work on movement patterns. Let's use DNS to assess the whole body. Let's use DNS to train the motor control system and to get this person moving better. So I hope in these two examples of a derangement and a dysfunction, you can see how DNS and MDT complement each other. I think any patient who comes through the door needs an MDT assessment so that you can rule out derangements, rule out dysfunctions, rule out a static postural syndrome. And if you can rule out derangements, dysfunctions, postural syndrome, or the other category, or you might be in the other category with a motor control issue, go right to DNS. If you find a derangement, let's reduce that derangement and then work on the motor control. If you find a dysfunction, let's figure out how to remodel that dysfunction and then go into motor control. If there's a postural syndrome, let's find that aggravating posture and then go into motor control. And then if we have the other category, let's find out, do we need to refer this person? Is there something deeper that we need to find? Or is this person maybe someone who doesn't fit in the derangement, dysfunction, postural syndrome, but are someone who needs spinal stabilization? DNS is right there. It's perfect for it. So lots of opportunities to integrate these two systems together. I'd like to go back to one of the first things I said, and the thing that really is strong about these systems is that they focus on utilizing the principles in your clinical reasoning, utilizing principles as part of problem solving, and being systematic. That's the great thing about these two systems, is that they teach you how to think. Thank you for listening. I'm David Reese. You can contact me at athletictrainer@gmail.com or at my website, www.dnsflorida.com. If you'd like more information on either MDT or DNS, you can go to the websites listed on this page.